so much for inviting me today to join this fabulous room. I know that you all have your own reasons for being here, but I have to, one of my disclosures, without any financial disclosures, is that connecting with you all is actually part of the reason that I am here. And then in addition, I want to share with you why this is a topic that I like to speak about. And whenever possible, I like to introduce the fact that near misses and failure is also part of healthcare. And I like to actually describe my own failures or near misses. And so that's actually the impetus for this talk. And I'll reflect on a patient that I saw really at the beginning of my medical career over 20 years ago, and some of the learnings that I took from that case. When we think about pediatrics, we don't actually think about back pain that much. When we look at kids here with a variety of symptoms, you'll see in the upper left-hand corner an example of a child coughing. Who has seen a child coughing in the last month? All of us. Okay. Who has seen a child with abdominal pain in the last month? All of us. Who has seen a child with crying unexpectedly, not quite sure what's going on, just some general fussiness in the last month? All of us see these things. And so when I think of back pain, the reason I think it's important to slow down and look at it a little closer is, unlike all of these situations, I'm not personally faced with pediatric back pain that often. So as a result, as an emergency physician, I deal all in the concept of the red flags and looking for the worst thing. So I recognize that when someone comes to see me at the Sick Kids Emergency Department, my approach to cough is possibly a little different than someone that has the opportunity to follow them through time or has a relationship with them. So when I see someone with cough, before I see them, what I'm actually thinking is, how do I know you don't have a foreign body, right? Small percentage of patients, but that's the way that my history and my physical is all geared, is proving why you don't have this bad thing. When I look at the child with abdominal pain, I'm thinking, how do I know that that's not the diabetic ketoacidosis first presentation? Again, not at all something that's likely, but it's a red flag thing that I've been taught in my training to look for. And the same with the crying. How do I know it's not a corneal abrasion? Thinking about all those other reasons that someone could be presenting that are less common. So the reason that I want to frame the discussion in this way is when I think of back pain, I don't have that automatic algorithm necessarily because I'm not seeing these patients as often. So part of what I would like to introduce to you is just my own reflections on how I've come to approach back pain after that first patient that I'll tell you about. So we're going to discuss some of the etiologies. Those of you that practice family medicine will probably be a lot more facile at this than I am. So that is another disclosure, is pediatric back pain is a little bit more tricky for people that only see kids because it's not quite as common. And then lastly, really just thinking about an evidence-informed approach to the management. The reason I say evidence-informed and not evidence-based is because there's really not a lot of evidence. Pediatric back pain is so rare that there's less than 2 or 3 observational studies when we specifically look at the emergency department population that even think about pediatric back pain. So just as a guidepost for our short, less than 15 minutes left that we have to talk, I'd like to just reflect on the questions that we ask these patients, what we're looking for in our examination of these patients, and again, the ever-important red flags that we all are looking for, thinking about if we will pursue images, what they might be, and then also just reminding ourselves, anytime we have a little bit less of a frequent presentation, maybe those are the kids that we're going to be thinking about referring a little differently and thinking a little bit more critically about. So, for those of you that have seen some of these pediatric kids with back pain, a lot of these questions are just sort of our bread and butter. It's just sort of the things we learned in medical school, getting a little bit more information around some of these patients. So, for example, the child that I first saw, the over 20 years ago child that I saw, was a young 4-year-old girl who was being brought in for really nonspecific symptoms. and wasn't necessarily coming in with just the chief complaint of back pain, but something was hurting when she was moving. And so some of the questions that we would ask in those situations were, is it an acute pain? Did it happen at the playground and then ever since then you haven't been able to move around? Is it worsening? Is there a specific limitation of activity? Is it happening during the nighttime? You can tell that, some of these are a little bit more concerning to us. In addition, is there any alleviation with some of those over-the-counter pain reducers, things like ibuprofen or Tylenol? Some of the other things that we think about is age. This is a huge one in the pediatric population. There is very much a dichotomous population difference in the way that we approach pediatric back pain. If you are under 10, our literature shows us that you are much more likely to have a pathologic cause. What we now know is that if you look at 12 to 15-year-old children, their incidence, their annual incidence, might be 10 to 12% for someone that actually ever complains of back pain. By the time you get up to 15 years of age, the average kiddo is likely to, over 50% of kids will have ever complained of back pain. If you take away that over 10-year-old population and move down to the really young kids, less than 5, less than 8, it is an exceedingly rare complaint. And so that's part of the reason that I discuss this with you today, is because it is such a rare complaint. How do we decide how seriously to take it? Because in general, the older children will be much more likely to have a less concerning and less pathologic etiology. The other things we might ask is weight loss, fevers, chills, and malaise. Things that are concerning from a neurologic standpoint, numbness, weakness, and paresthesia, and obviously things like bowel and bladder issues. So the thing that I will reflect to you on my own patient, the 4-year-old that was being brought in with something not quite right and maybe some discomfort in her back, but nothing specific, is she was young. She was a 4-year-old. She did not have weight loss, fever, chills, or malaise, numbness, weakness, or paresthesia. Most of these things were negative on her. The examination. So this is where I made my critical error that I want to share with you. This really thinking about how to examine a child that's coming in with any concerns of back pain. And it's the most basic thing. I'll tell you right here, this is why I think that it's so important with all the learners that I teach. One of the first things I do is for any presenting complaint, I usually tell them what I've missed in the future, and that's how we're not gonna miss it again. So standing and walking, we're actually gonna stand our patient up. We're gonna assess to see that their shoulders are level. And so this isn't necessarily intuitive for people if you're not looking for things like scoliosis as part of your practice, if you're not used to dealing with the average kiddo that actually can stand. This is the assumption that this kid can stand on their own. You're gonna be looking at both their hip, their spine, and just their stance. How comfortable are they holding themselves? When they actually walk, is there a limp? Also, you're going to be looking at some of the other things that aren't really directly related to their back. Is there a rash present? Are there bruises elsewhere on their skin? Do they have any cafe au lait macules? Any hairy patches or dimples at the inferior part? In addition, we're going to use our hands. We're palpating, we're looking for where is that pain? Is it more paraspinous? Is it in the middle? Is it diffuse? Is it specific? And in addition, just remembering that when that focal pain is easier to identify, it's more likely we're actually going to find an etiology. The challenge with back pain is over half of them, we actually can't figure out what's wrong. But what we want to arm ourselves to do is actually figure out, for the ones that there is something wrong, making sure that we're doing the proper things to figure that out. So when we know that there is non-focal pain, we know that that's a little bit trickier to figure out. When we're inspecting, we're actually having people forward bend. And again, as an emergency provider, I'm not actually necessarily screening for things like scoliosis, but we do know when people are actually forward bending, we see some of that asymmetry. It's going to be a little bit more suspicious for us. And as well, something that I'm not necessarily used to doing for the kids is actually having them range themselves with flexion and extension at the back as well. When it comes to the neurologic exam, again, pretty tricky in certain kids, especially those younger ones, but keeping in mind that looking at both sensory, motor, and reflexes and thinking about weakness. The younger the kids get, for sure, a neurologic exam is quite difficult, but of all the times when it's going to be important, it is thinking about some of these back pain kiddos. And for me, this is really the meat of the material, is just reminding ourselves when to slow down. When we know that over half of back pain won't actually, quote, get a diagnosis, when they come to see me and they want an answer, they've been waiting for 5 hours, I may not be able to give it to them. However, I will definitely press myself to think a little harder and come up with my own approach to look a little deeper if any of these flags are firing off in my brain. So when I'm walking in the room, the number one thing I'm thinking is it just their back, or is there anything else happening? Do we have any of these more constitutional symptoms, fevers and night sweats? Obviously, all of us start thinking a little bit more of some malignant process going on when we see some of those flag off. Things that are worse at night or wake us from sleep, neurologic symptoms, and thinking about acute or focal pain that's not improved by NSAIDs or Tylenol. Anything that's sort of constant and worsening rather than coming and going with activity, and obviously, the patient that can't walk. And so that disclosure for me, for that patient that I had years ago, was that I was somebody seeing a patient in the emergency department very early as a learner. I saw this 4-year-old girl. I had palpated everything on them. I couldn't actually find any pain anywhere on this young girl's body. And I came out of the room and I was trying to think. I couldn't find any etiology to actually commit to ordering an x-ray because nothing was tender, including in the extremities, including in the back. And as I was starting to think about discharging this patient home, I realized that I had never actually gotten this young 4-year-old girl up to walk. And that might sound so basic to all of you, but for me in the emergency department, the patient had been sitting in that stretcher for over an hour. But I realized I was really about to discharge someone home. The mom would have just carried this 4-year-old girl out, and I would have never known it. I came back, had her actually walk, and realized she can't stand on her own. This was the key to me. So something so basic, I was very near discharging her, and then I realized that something was missing, and this was my red flag. And I wasn't as far along to recognize what a big red flag this was. And based on that red flag, I realized, okay, I think I need to look a little harder. Let me think about this a little more. And I actually ordered some x-rays and specifically found the diagnosis that I will tell you about as we go through some of these other diagnoses that we're gonna have on our mind. When we think of imaging, for many of you, the plain films is where we're gonna start and we're gonna stop. And the average patient may not even need those plain films. But for those that you do feel where the trauma, there's a specific trauma or a history that just doesn't fit with muscular or strain, which is gonna be the most common ultimate diagnosis, you might think of images, thinking of oblique films if you're thinking of something like spondylolysis, and thinking about flex-X films for something like spondylolisthesis. There's a whole nother specific talk that we could go on for half an hour about how to interpret those films. What I will say is if you're not someone that routinely interprets them, obviously you're going to be looking for your radiologist to help you with that. And then lastly, I just want to review some of these common diagnoses that we see with back pain that's in the back of our mind. The most common is going to be something just muscular and just mildly musculoskeletal that's not specific. But these are the things that we want to have in our mind. Discitis, although it's very rare, is actually, of the pathologic causes, more common in pediatrics. So it's the most common in kids that are less than 5, and that's what my kiddo had, right? So that 4-year-old that was just non-specific, wasn't actually, there was nothing about the history that was flagging me off to look there. That's actually in the end what she had. And what I did was I had started with those plain film x-rays, saw some disc space narrowing, and then sort of went on to further imaging. That kiddo didn't have fever malaise, but again, when I finally did remember that that red flag was there of not walking, that's when we stood her up and realized that she couldn't stand. Other things to think about: vertebral osteomyelitis and leukemias, osteoid osteomas. And remember, with things like osteoid osteomas, this is where you might get that history that it's improved by NSAIDs and worse at night. So that's why some of those questions come into play. But if you'll see here, there's a lot of those red flags that are flagging off for some of these, right? Fever, bruising, malaise, sort of those constitutional symptoms. Other things, from a herniation standpoint, this is going to be an older population. We don't see this quite so much. You'll see some other diagnoses here, less important for me in the emergency department, but definitely some things that I still think of, spondylolysis and spondylolisthesis. Both of these are things that we can look at with some plain film special views. But as you can see, there's a lot to consider here, and I think one of the challenges is looking for that needle in the haystack, thinking of those chief complaints and presenting symptoms that are a little bit less common for us. I, for myself, have had to think about a little bit more critically and develop a different approach, because I think all of us, we walk into the chest pain room, if you're a family physician, we walk into the cough and fever room, and we have exactly in our mind the questions we're going to run through. So what I would leave you with is thinking about the specific questions to answer all those red flags you have for a pediatric back pain patient. And the main things to rule out is neurologic, trauma, and infection. Those three things essentially highlight all the three elements of badness that you might see, other than leaving yourself with something much more mild like a musculoskeletal case. Thanks so much for your time. I'm happy to answer any questions.